Good evening, everybody. Welcome to the CMTA webinar here for August of 2015. Tonight's webinar is the care of the pediatric patient from a physical therapy perspective. And I've had a really nice opportunity to chat with Katie and Amy here, who will be presenting this evening. And I think you're going to find this to be a really interesting topic. The webinar is going to cover, some of the goals of physical therapy and physical therapy services, the common areas of physical therapy practice, specifically for pediatric patients, and other health and wellness topics. And as you saw in the description, including community activities, stretching, bracing, and peer support. For everyone else in the webinar, you'll see there's a place you can ask questions. We'll be monitoring the questions as we go through the webinar this evening. And Katie and Amy have agreed that if a question is relevant to a topic or slide through off that time, that we'll be able to jump right in with the questions. Any other questions that maybe a little bit more off topic, we'll save towards the end, and we'll see what we can answer in the time allotted.
Okay, so I'm Kate, and like Bob said, during this webinar, Amy and I hope to discuss the management of children with CMT from a physical therapy perspective. We will discuss the goals of care or overall management, the areas of practice for physical therapists as it pertains to children with CMT, and some overall health and wellness ideas, again, as it pertains to children with CMT. I know I don't need to present the pathophysiology of CMT much to this group. However, there were a couple of things that I wanted to remind you of because they play an important role in the management of children with CMT. The first being that CMT is a disorder of the peripheral nerves. So that's the nerves that connect, the connecting nerves that go from outside of the brain and spinal cord to the muscles. And they're responsible for transmitting messages for muscle activation to the muscles. And because these nerves may not work well in certain parts of the body, muscles don't get stimulated to work, and this results in weakness or atrophy of the muscles. The other important thing to remember is that CMT is actually a group of heterogeneous inherited neuropathies. And I think they're up to about 80, maybe closer to 90 even at this point, different genes that have been identified as disease-causing genes. And as a result, the physical presentation or the phenotype of CMT is highly heterogeneous or variable as well. And furthermore, it's important to note that even within the same genetic lesion, so for example in CMT1A, there's still a great deal of variability. And we often see differences in the physical presentation even within a single family. And this is really important to know when we discuss the management of CMT because there's really no one answer fits all situations. And I think this highlights the important role that physical therapists play in the management of people with CMT because as physical therapists, we evaluate each individual that comes to see us, and based on our findings and based on the patient's priorities and their goals, we determine an intervention. And so while PT is highly individualized, I would also say that there are some overarching goals of care that pertain to individuals with progressive neuromuscular conditions such as CMT. And those goals are to maintain optimal health, to maximize functional abilities, to delay or prevent secondary complications, and to improve or maintain the quality of life. In terms of maintaining optimal health, we encourage regular well checks with primary care physicians, and that's just to assist in maintaining optimal health, and primary care physician looking at all aspects of the person's overall health. And in an individual with who have a condition that may affect their strength, it is important that they maintain an optimal weight. And so sometimes working with a nutritionist, not only for assistance with weight issues, but also to optimize energy levels may be helpful for individuals with CMT. We often refer to functional abilities like getting up, walking, climbing upstairs as gross motor skills in the pediatric population or in children. And these skills are developed as part of overall child development. However, this development might be delayed in some individuals who have challenges to their strength and to their sensation. And some of these skills, therefore, will take time to develop. Physical therapy services are often used at different periods of time to assist with gross motor development. So if a child's having difficulty climbing stairs, for instance, they may seek out a physical therapist to help with obtaining that specific goal. Otherwise, regular play, regular physical activities, and just overall practice of gross motor skills can help facilitate the development of these skills, and therefore it will help maximize functional abilities, one of the goals. Other ways that we sometimes will look at helping maximize functional abilities in children with CMT is through the use of orthotic bracing or the use of assistive devices. Currently, there aren't any specific evidence-based guidelines, per se, regarding orthotic bracing in individuals with CMT. There is some evidence that AFOs or ankle-foot orthotics may improve walking efficiency in individuals with CMT. And so that's for people with CMT, they often will have weakness in the muscles called the ankle dorsiflexors, or the muscles that lift the foot up. And in that situation, individuals have to use their hip flexor muscles, which are higher up on their leg, and they lift their leg up to make sure that their foot clears the ground when walking, and then that foot can advance forward. And so walking like that, something that we would refer to as like a steppage gait pattern, uses a lot more energy to walk. And so the use of ankle-foot orthotics can improve a person's gait by assisting with that foot clearance when they swing the leg through, and that results in using less energy during the process of walking. There are many different types of braces. They can be made of polypropylene plastic, which I don't have a picture of here on this slide. But the other ones that we often will look at are the carbon fiber braces, and those are the two pictured on the left. There are two different types of carbon fiber braces that are often used in individuals with leg weakness. The thing that carbon fiber offers is that they're very lightweight, but still pretty high strength, and so they can accomplish the task. These type of braces mainly help with just lifting the foot straight up. Sometimes polypropylene plastic braces are more necessary when people have the need for stability all around their ankle and in every direction. And sometimes those more molded braces or custom braces can help provide a little bit more ankle stability. The other devices here that may also improve walking, the supramalleolar brace, that's kind of the blue brace, is a brace that's sometimes used early on as a child is learning to walk, and it just may help give some ankle stability and ankle positioning to help with obtaining the goal of walking, sometimes in a child that's a little bit more slightly delayed in obtaining their walking goals in early childhood. And then the other brace in the bottom right-hand corner is called an ankle stabilizing orthosis, and this may be used to provide additional ankle support. It's often the type of brace that somebody would use after they sprain their ankle, but sometimes we can use it preventatively, and again, just maybe used for different times when it would be needed, walking on uneven surfaces or when playing sports or something like that. The overall team will help you and your child make decisions about bracing. And I think there have been other webinars that discuss specifically orthotics and bracing, and you may want to refer to those as well. But we kind of help as part of the team thinking about analyzing gait and how people are using their muscles for walking, and whether or not bracing may be something that may be helpful. It doesn't come without some cost, literally cost. There's sometimes insurance coverage doesn't fully cover bracing, but it's also they may be limiting as far as not allowing a child to use stronger muscles. So sometimes the calf muscles, the muscles in the back of the leg, are actually pretty strong, and when you put a brace on them, because they can't fully use those muscles when walking, those muscles may also become weak too. So it's a team approach, and really requires a thought process by the whole team and the family and the child, and kind of where the goals are. But I think it's important to note that these type of things may be used to help maximize a person's walking ability. The other thing that sometimes we'll recommend or discuss as far as maximizing functional abilities is the use of assistive devices. And those can be things like walking sticks or like a hiking pole, and then further on either walkers or scooters. So walking sticks and canes and hiking poles, all of those can help an individual with their mobility by basically assisting with balance during walking tasks. They provide an extra sensory input through the hand to help people understand better, their brains understand their position in space better, and really can help improve balance. So again, they may be something that's not used regularly, but if you go for a hike in the woods, that may be something to consider having your child use, just to give them a little bit of extra stability when they're walking. And I know, hiking with my two children, they absolutely love using their hiking sticks. So maybe something easy to provide a little bit more assistance in a challenging environment. Walkers obviously will provide a little bit further support, and then scooters can be used if children have difficulties walking long distances. There are different types of more powered mobility options for children that may have trouble keeping up with their peers, either in an extracurricular setting or friendship setting, social setting versus a school setting. So there may be times that, or even family settings, if you're going for a walk around Disney World or something like that, a scooter may be an option for longer distances. But like I said, there's other options for kids. I mean, it could be, a manual device or a power device, but something to help them maximize their abilities in situations where their endurance may be challenged. Another goal, overall arching goal of physical therapy and the management of children with CMT is to delay and prevent secondary complications. And exercise can be absolutely instrumental in delaying or preventing these secondary complications. Exercise is also really important for overall health and wellness, and therefore, exercise of all types should be incorporated into daily life. And one role of a physical therapist may be to provide or prescribe specific stretches or strengthening activities that may meet the goals of an individual child. So that's under the range of motion and stretching aspect of things. And then strengthening, there may be specific functional activities, for instance, climbing up a single step, that may provide strengthening benefit as part of an exercise program. And then aerobic activities in children are often accomplished during regular play. Swimming is a great form of aerobic activity, and it's great for individuals with neuromuscular conditions such as CMT. And I think Amy will speak more to this in a little bit. And I am going to turn it over to Amy.
Hi, everyone. So continuing along the lines with delaying and preventing secondary complications, we want to make sure that the range of motion of the child is maintained as much as possible, despite tightness that may just occur as part of the natural progression of CMT. we have a couple of ways of doing that in addition to daily stretching that we might consider, or the medical team might consider using as part of physical therapy. You might consider serial casting, and Rose et al. Put out a study in 2010 stating that after 4 weeks of serial casting, improved range of motion was noted in comparison with the non-intervention control group. However, after 8 weeks, there were no significant differences between the groups. So with that data in mind, I personally, as a physical therapist, have not seen it used often with kids. However, I think that for some situations it is utilized and may be an effective way. Another concern with these children is that, as again part of the natural progression of CMT, we might have sensory impairments that we're dealing with. And with serial casting, you are casting the ankle in a position of as great a dorsiflexion as they can accomplish and holding that in that position. So they're getting this constant static stretch and then taking them back to the physician to have it recasted at a little bit greater dorsiflexion a couple weeks later. And sometimes with sensory issues, you run the risk of a potential breakdown of skin in there. So again, it's not without its challenges and risks, but in certain situations, the team might decide that that is an optimal way to go. So another option is splinting, and you will see the picture of my son's ankles there, and his wearing his night splints. He is affected with CMT type 1A, and what it is just as it says, it's a dynamic splint, so he can what we call plantar flex and dorsiflex his foot within that brace. He can wear them for a walk to the bathroom if he desires, but they're not meant for walking. They are night splints, so they're on him when he is sleeping. And it has a little spring in it. So every time, he would tell you, every time I push my toe down, it pulls it back up. And so the tension is adjusted on it. So when we first receive them from the orthotist, they're on his ankles at a very low load, just kind of for him to get used to them. And then we go back and the orthotist tightens it about a month after that we first receive the braces. He tightens it so it's a little bit more tension on it, but it's still a very low load. And then he's taught me how to tighten it over time. And my son at age 6 will tell you that on nights when we don't wear them, say we spend the night at grandma's or something like that, his legs feel better when he does wear them. And so because he has made that connection, he's pretty autonomous with putting his braces on every night at bedtime. It's just part of his routine. He can do the straps himself, take his little feet in and out of them as he needs to. And I think that encouraging autonomy with kids, whether it be for exercises or splints, is so important for helping them with long-term management of this disease process that they are affected by. So another overarching goal that Kate expressed at the start of our presentation was improving and maintaining quality of life. And maintaining the ability to walk without falling is crucial for these kiddos. As physical therapists, we will work with patients and their families in designing interventions that will improve their quality of life. And in a study done by Burns et al. In 2010, they looked at the quality of life of kids with CMT, and major concerns affecting their quality of life were the presence of leg cramps, hand tremors, shortened step length, and ankle flexibility. Those were all contributing to decreased quality of life for these kids. So again, as physical therapists, we look at those sorts of things and try to say, if there is pain associated with leg cramps, is there anything that we can do to help with management of that? And sometimes the pain is related to more structural and functional problems that are leading to perhaps the cramps. And again, is there anything that we can do from an exercise standpoint or a bracing standpoint or an activity modification standpoint to help modify that? And again, it's very individualized. Relationships with peers, siblings, and family members are very important for these kids, for all kids, right? But definitely for children who might see themselves as a little bit different physically. And as physical therapists, we might assist a family or a child in finding ways for a child to, quote, keep up. And then also just answering questions to the best of our ability and honestly about statements such as, why don't my legs work like other kids? And when a child is not developmentally on target, whether it's physical reasons or anything else really, and when they're not on target with their peers, that can really set them up for having issues with anxiety. And so guiding the family in the right direction in terms of helping a child with management of that also might be part of our role. If you think about that anxiety thing and think about the reasons that a child might come up with in their own head as to why their legs might not work like their peers, often our answer might be a very lesser fear than what they might have imagined in their heads. So we want to, like I said, be as open and as honest as we can regarding that.
Amy, I have a question here for you, if you have a
Sure.
moment. Someone was asking about the, just going back one screen to the splinting. Does the splinting help with a tight tendon in the back of the foot?
Yes, that is the goal. So the concern is for a plantar flexion contracture developing, and when a muscle is so tight that it becomes a contracture, we can no longer get the full range of motion with just a stretch. And so we want to prevent a contracture from developing. And so the goal is to keep that muscle and tendon at an adequate length so you can achieve the normal range of motion. And if you develop sure, can I just add? If you develop a plantar flexion contracture, then the foot can't hit the ground flat or in a what we call a plantigrade position, and then clearly that's going to impact the person's ability to walk because they'll end up on their toes if the foot can't come flat.
And I would add that this all begins because of the muscular imbalance that happens when certain muscles are weaker than other muscles. So in individuals with CMT, the lower leg is often affected early on, but the muscles in the front of the leg are inherently weaker than the muscles on the back side of the leg. And so even though that they may both have some weakness, the tendency is still for the foot to not be able to hold itself up against the really tight, strong calf muscles. And so that muscular imbalance is what is really the reason that we work on range of motion and stretch exercises or splinting to help maintain that range of motion caused by a muscular imbalance.
Right.
Amy, there's just one really quick question here on the second bullet point. What does LE stand for?
What does what stand for, I'm sorry?
LE in the second bullet point.
Oh, lower extremity.
Okay, there we go. Thank you.
Great. So if we continue on, areas of practice as a physical therapist, I think one of the cool things is that we have so many different areas that we might practice in. And a child affected by CMT might see a physical therapist in a few different settings. Acute care physical therapists might be involved when a child is in the hospital for an illness, injury, or post-surgery. The physical therapy goals in this setting often relate to restoring the child's mobility to function in their home setting after discharge. The child might need to learn to walk with a new assistive device, learn new stretches, learn how to don or doff a new brace or splint, or restore their baseline mobility and strength level post-illness. So acute care is really that hospital-based therapy that a child might receive in that setting. Outpatient, a child might require outpatient PT services when he or she has sustained a temporary orthopedic injury, or if a child has decreased strength, decreased balance, or decreased range of motion that impacts their overall gross motor skills and or their ability to keep up with their family members or peers. With the neuromuscular disease, the affected children will have these impairments long term, so the goal is to help the child manage their symptoms and become autonomous with managing them. Or I said the child, but the child in collaboration with the family, depending on age of the child. Treatment in this setting may include learning new stretching and strengthening routines for home, learning about different options regarding bracing to optimize mobility or gait efficiency, and allow a child to best participate in their active lifestyle. School-based physical therapy is involved when a child is struggling with accessing, participating, and making progress in their educational environment because of their physical impairments. Treatment may be one-on-one in a group setting, or a therapist may direct a classroom helper in how to assist the child with the exercise program. Depending on many factors, including state regulations, funding, therapists employed covering the district, etc., a child may or may not receive school-based services. An IEP needs to be in place, or an individualized educational program needs to be in place, for PT to commence in the school system, and most likely the child will be pulled from academic instruction to receive care. The frequency of treatment sessions will vary depending on the child's goals and the need. For example, a child may have mastered the skills necessary to negotiate elementary school and no longer require services in that setting. He or she might move on to middle school and face new challenges, including negotiating busy hallways with a limited time frame, carrying books up and down the stairs, etc. And services may need to restart in this environment to help the child succeed in this new school. So take-homes there, I think, are that it can be episodic care, even throughout the year. A child might require more frequent services, say, in the fall of the year, and then maybe it drops down to, say, once a month, kind of on a consult basis as the therapist is in and out, and then maybe something happens health-wise and the therapist is in there more frequently in the spring. It is a team, not just a medical team, but an educational team that is working with the child and helping to determine appropriate goals and needs based on the school-based environment. So for a physical therapy evaluation, really in any setting, we're looking at a couple key components. There's an interview where we talk to the child and the family about the symptoms they're experiencing, functional challenges, daily activities, responsibilities, and goals. We're going to look at the skills that they're speaking with us about and as part of our assessment, and these are going to include negotiating curbs, ramps, playgrounds, large steps like those involved in getting on and off a school bus. So again, as part of that assessment, we're also taking into account tests and measures of strength, range of motion, function that we're doing, and then we're looking at implementing goals and a plan of care, including treatment frequency and duration. Physical therapy, as Kate mentioned earlier, is an individualized service, and we are hoping to learn from our interview with you and your child what is important to you so we can help set up appropriate goals to help get your child back out into the world and be as active as they possibly can for as long as they can be. There's lots of problem solving involved, and there's no right or perfect way to go about managing the challenges that a child with CMT faces. So please just be open and honest, and we'll work together to help you out as much as we can. So health and wellness, as you would, like regarding community activities, as you would with any child, we encourage you to try different activities and try to find a good fit when it comes to their extracurriculars. As you consider your child's activities for maybe the upcoming school year, you might ask yourself, do they have a physical activity that they're participating in? Is there a social activity that they're participating in? And as I said, maybe encourage them to try something new. I would encourage you to not be afraid to speak with a coach or a teacher about potentially modifying something if you observe that it might be helpful for your child. If your child is consistently struggling with something regarding their physical ability to participate, you might seek out a physical therapist who could help you problem solve and help you maybe better understand why. I will tell you, I have 2 of my 3 kids that I know to be affected with CMT type 1A, and my daughter was a very excited participant in her gymnastics class for years. And when she was 6 and a half, I picked her up and she was very sad, and she told me that every child in her group got told good job over and over again, but she didn't, and she was so frustrated that she can't do a handstand and return to stand afterwards. She kept falling onto her knees, and that she just couldn't do it. And so me, a determined mom physical therapist, was going to figure out why. And I realized after watching her try at home, she doesn't have the hamstring length or the muscle behind her knee to be able to extend her knee to get her foot down before she crashes down onto her knees. And there was really no simple solution beyond that, and she was disappointed, discouraged, and sadly, we did not try to modify, but she asked if she could, instead of gymnastics, try out swimming for the next kind of time that we went to sign up for activities. She had a very successful swim season, and that was such, I've shared with Kate, such a promising, rewarding aspect of watching her kind of develop as a person, as a mom, to realize, wow, we really just needed to change activities because now she's very happy and proud and excited to be part of the team, versus kind of really down on herself that she couldn't meet the expectations in the other environment. So consider those things, and sometimes, like I said, it takes somebody whose brain is thinking about it from more of an anatomical perspective to realize why the child is struggling as much as they are. So you might consider some activities that encourage activity at home on a rainy day. I included the link for something called Cosmic Kids Yoga, which I recently learned about, and there are these fun yoga adventures that kids go on, and you can link to them all. They're on YouTube for free. Other things you might consider are like dance video games, things that encourage coordination, neuromuscular planning for the kids. And certainly when the weather is nice, send them outside to play. Orthotics are, as Kate already discussed, something that might be helpful in setting up an optimal foot alignment for the child's activities. And again, seek out the guidance from a physical therapist and orthotist if this is something that you feel like might be helpful for your child. Peer support, I think, is really important for the children involved as well as for the parents. The CMTA has a parents group that is on Facebook called CMT Parents. If a child is between 13 and 21, there is a CMTA Youth Facebook page. At CMT family conferences, there's often a youth outing component, and again, I think that it would be very exciting to meet other people that are impaired in similar ways or different ways, and help our young people gain perspective of where they are physically and how others best manage these challenges that they face on a day-to-day basis. There are certainly more resources on the CMTA webpage. I would encourage you to reach out to others and problem solve together in terms of what are the most ideal resources in your community if you're so lucky to have met another family also with children affected. And lastly, from a perspective piece, I think kids really just want to be kids. So try not to stress too much or over-medicalize things. I know I can certainly be guilty of that in our family, but really just let them be kids and enjoy their worlds, and encourage them to challenge themselves and negotiate it as best they can. And we step in and help problem solve where we can, as you would with any kid. And I think at this time, if there are any questions, that's pretty much our presentation as we had it prepared.
Well, we've already gotten several questions about whether or not there'll be handouts. So obviously you guys had a lot of really positive things to say about this, and people, I think, want to get access to these resources. I will say that these webinars will be posted on the CMTA website, so you'll be able to review them again. And I think anybody who wants a handout of these can email directly either Katie or Amy through the CMTA and request that information. I'm sure they'd be happy to share their resources with you. And as Amy just said, there's many more resources on the CMTA website to help out with this sort of thing. If anybody else has any further questions, I'm sure Amy and Katie would love to discuss things further. So here we go. Always good to ask for questions. Is Botox something that helps with reducing the overpowering element of I'm not sure what this means, gastrocs, or does this mechanism not work with CMT? I don't know if you guys know anything about that.
Bob, could you repeat that? I had trouble hearing you.
Okay. The question is about Botox, and does it have an effect reducing, I'm not sure what gastrox is, or does this, does it work? Is there any, I guess, any benefit of Botox to CMT?
I mean, I can take a stab at that. So Botox basically is an agent that can be used to induce the temporary paralysis of a muscle. And the gastroc muscles are actually the calf muscles. I certainly have seen it being used in other neurological conditions as a way of controlling some of the overpowering aspect of certain muscles. I think in CMT, my thoughts would be that there's a muscle imbalance because some muscles are stronger than other muscles, but I think the concern would be in use of Botox is that if you temporarily paralyze the calf muscles, that you would also lose the function of the calf muscles. And the calf muscles are really important in propelling our body forward when we walk. So if you can imagine, then you kind of would end up with somebody unable to propel their body weight forward in a walking situation. Now, that being said, I think it would be highly individualized, and if the muscle imbalance is so great that that's something that needs to be considered, I'm sure the medical team would, discuss the pros and cons of doing something like that. But my initial reaction is just the fact that those muscles are really still important in walking, even though they can make it challenging to maintain the range of motion of the ankle joint. Anything to add?
No, I think again, as Kate said, if we impair the function of the gastroc, it would be very challenging for ambulation or walking to take place. And yeah, I don't have anything. Clinically, I've never seen it. I just tried to do a kind of quick lit review to see if there was something that, literature-wise that I might see just in the last 2 minutes, and I didn't see anything pop up in terms of its use. So I don't know. Certainly every person is a different individual, and the medical team would be best to assess that, if it might be something that might be helpful. But as far as I know, I haven't seen it used clinically.
Okay. We have another question here about can you speak to adaptive PE on an IEP versus PE accommodations with a 504 plan?
I have not been in the school-based setting professionally. I've worked in outpatient settings and hospital-based settings, but I've not found myself in the school-based setting. I think the best answer to that is no. I don't have that experience. I would encourage you to ask questions at your school district level, though, because they certainly should be willing to discuss that with you.
And I would also say that I don't have school-based experience as well, but the things that I understand from the families that I work with is it's very different school to school based on some of the resources that different schools have, rural versus urban, and even the state regulations between different states. So again, I would agree with Amy. It's just to discuss with your school, and then maybe with even in your region, looking at different school systems and talking to different school systems to see how things may be handled. But I think it's probably definitely very individualized based on your child as well as what the resources of the school district are.
Okay, so we have another question here about how much does fatigue play, fit into CMT, and do you have to teach pacing of activities to your patients?
will say that fatigue plays a major role in the management of CMT. If you think about, Kate previously mentioned with the discussion of orthotics, gait efficiency, if you consider the extra muscles that a child or an adult affected with CMT need to utilize with every step that they take and every activity that they do throughout the day, and the extra concentration required just for simple skills. Again, when you think about children, maybe in elementary school, the cutting, the pasting, the gluing, taking on and off the hands, fine motor skills, that they really have to focus on if there's weakness in the hands, which we now know is present right from the get-go. I think that, some extra effort is required with everything throughout their day. And so fatigue is definitely, and just as part of the natural progression of CMT also, fatigue is going to play a part. So pacing of activity is definitely something that we're working with folks on in the clinic, as well as energy conservation. And again, things like orthotics or assistive devices come into play in terms of optimizing a person's function to allow them to have the energy to do the things that they want to do throughout their day. Kate, do you have anything else to add?
No, I think I completely agree.
Another question here about physical therapy and activities. What role can physical therapy play with a child who has painful nighttime leg cramping?
The leg cramping is something that we're trying to understand more about in individuals with CMT. The fluctuation day to day that patients report in their cramping. Sometimes physical activity increases their cramping, sometimes physical activity decreases their cramping. So it's not something that has been well studied or well understood at this point, but I do know that there are efforts currently ongoing to help with management of this, of the cramping, and understanding things that may increase cramping in individuals with CMT. Something that we sometimes try is the low-load dynamic splints can sometimes help by keeping the muscle at a certain tension throughout the night. That may play a role and help manage it. Even just regular stretching and yoga, again, may play a role. It's one of those things right now, though, that we don't have a great understanding about.
Okay. Something that we might encourage a family to do is kind of to try to identify patterns regarding the child's activities during the day, and if there is something that seems to be a contributing factor for that individual, we can certainly try to help sort through that, and if there are stretches that aren't being done that need to be done, including those in their daily regimen, and just trying to, it's a little bit of trial and error and problem solving, working with the family in terms of optimal management of that. But certainly, again, when you go back to the fatigue comment earlier, like if a kid's not sleeping through the night because they're waking up because they're in pain, again, it all just kind of compounds itself into more fatigue. So
absolutely,
definitely trying to manage that as best as possible is critical.
So I'm going to take two questions here and kind of mash them together. They're from two different people, but I think they kind of get the same thing. And they're trying to figure out, the first part of the question is, what outcome measures do you commonly use, like a 6-minute walk test or a balance test? And then at what point do you consider, powered mobility? And how do you introduce that to the child and the family?
Kate, you want to go?
So there are definitely a lot of different outcome measures that can be used. In the Centers of Excellence, I know that we often collect data using the CMT PEDS scale currently, and that looks at several different items: hand function, range of motion, power, gait, balance. So using that from a clinical research standpoint, and obviously that's more isolated at the Centers of Excellence that are participating in some of the research, we can tease out different pieces of that and identify areas that may need to be addressed from an intervention standpoint. Again, I think in overall pediatric physical therapy, there are lots of different tests and measures that look at balance, that look at mobility, 6-minute walk test. Sometimes it's probably used more on a research standpoint than a clinical standpoint, but there's definitely gross motor scales and I know things that we know, I guess, as physical therapists, that the Peabody is a scale that's used to look at gross motor function in young children. So there are lots of different tests and measures depending on the area of practice that the physical therapist is and the child is being seen in, and as well as what are the concerns that are bringing a child to seek out physical therapy intervention. That will often dictate which kind of outcome measures physical therapists may choose to use to better tease out some of the impairments that may be leading to some of the functional changes. Regarding the, I think the second, and correct me if I'm wrong, the second part of the question was at what point do you look at using powered mobility? Is that correct?
Yes.
That is correct.
Okay. It's one of those things that I guess I would say very, very individualized. It may be something that may be used just for specific activities. Like I said, for if a child's having trouble keeping up with a family or doesn't have the energy to keep up with a family for a long day at a park or on a field trip or even a shopping mall, then you may consider using powered mobility for those specific situations. That being said, I think the other important thing is to balance it with as much physical activity as a child can tolerate too. You know, there'll be times that if we help a child and family obtain a power wheelchair, is that we say, okay, that this power wheelchair would be used for these situations. Otherwise, I really want you to try to get up and walk around your classroom, or get up and walk, or make sure you're walking around your home environment, as long as you have the physical ability to do those things. And so I think a lot of times in individuals with neuromuscular conditions that are progressive, is it's kind of a stepwise change. You may just, you know, just need it for long distances for a little bit, and the weakness or condition may progress a little bit more as the child ages, and you may need to use it more frequently. But I think the initial when to consider using powered mobility is when the child is having trouble accomplishing the task that they are setting out to do, i.e. walking around a longer distance environment. Does that answer your question?
I think that was fantastic. Yep.
Dean, do you have anything to add?
No, I just would only add, you know, safety is a consideration too. Certainly,
absolutely. Yep.
Some folks come in and tell us that they fall 4 times each day, but they don't think it's a big deal. And I would say that's a big deal, right? Like when you take a fall, we don't want you to sustain a fracture or a head injury or anything else. We want to make sure that, you know, you're safe. And sometimes sometimes the patient isn't the best judge of that, but rather people around them can identify that better, especially if there's somebody who's used to falling. That said, with kids, my goodness, all 3 of my kids fall multiple times each day. And it's not because they need powered mobility. It's just because they're very active individuals who don't always plan ahead and crash into things and fall, right? So I think that, you know, work with your medical team and your physical therapist and figuring out what works best for the specific individual involved.
We have a question here from someone who has a child in physical therapy, and they're kind of on a scheduled visits, and in between these visits, the child is doing stretches and exercises, I guess, as they've been trained. So they want to know how long to keep going to physical therapy. Do you return for periodic visits? After, you know, do you go? What kind of, I guess, what kind of schedule should you be on with physical therapy, and where can you slow it down? Where should you pick it back up?
Sure, I'll take that. So you want the guidance of a physical therapist. This sounds, for lack of a better way of saying it, as long as you need it. We want you to learn how to autonomously manage the symptoms that brought you into the care of the physical therapist, whether that was pain or energy conservation management or lack of range of motion. That being said, because you're dealing with a neuromuscular disease, as physical therapists, we can't make it go away, right? It's something that's there, and we need to learn how to manage it. And so I kind of would say that it would be expected that you would see a physical therapist episodically, and when the kid is doing great and participating in their activities, and you know what you need to do in terms of stretching, and you're doing it every day, and you're not running into any barriers, you're good without physical therapy. But then when maybe the child involved hits a growth spurt, and the tightness that they have, like the muscles are not elongating at the same rate that the bones are, and so therefore you have more of that muscle imbalance and the tightness that is occurring, and maybe you hit a hurdle. The kid can't do the stretches that they normally do, or the brace doesn't fit the right way, because there's been some sort of change, and then that should bring you back into the care of the physical therapist again to figure out why, and then again what to do and how to best manage it in that particular situation. Or if there's a new environmental demand, for example, a child's going to be going to a new school district, or not necessarily district, but a new school environment. Will they need to negotiate the school bus for the first time? Or specific skills that aren't play yard skills but are everyday skills, like stair management, can be really critical in making sure that a child is kind of not singled out. Like if a kid can't do the monkey bars, that's not something that they're doing every day in front of their peers. But certainly doing the stairs and carrying their lunch bag up and down the stairs and being able to successfully do that and keep up with their peers is very important for their everyday functioning if your school involves stairs. Does that help answer? Again, whenever there is a change that you can't figure out, or that you have been unable to figure out how to manage regarding the physical capabilities, is an optional time to seek out the care of a physical therapist. That being said, when they give you a home exercise program and they discharge you and they say, keep doing this, you really do need to keep doing it, because they do get really tight if they stop stretching. And so it should be incorporated into their daily routine, maybe right before they brush their teeth at night. It's just part of their everyday routine to keep it going. Kate, any additions?
Thank you very much. We have a kind of a follow-up question on that, in that for somebody who struggles financially to afford physical therapy and to keep a consistent schedule with it and so forth, do you have any ideas on like how to approach a physical therapist and try and get as much quote unquote homework as they can, so that visits can be less frequent and less of a financial hardship?
I would say be very open and honest on day one and explain that situation. I think that any of us certainly we don't want your care to be inhibited because of a financial challenge or even a time challenge. We want to make things as easy as possible for you to be able to manage that situation. And certainly if you're motivated to do that homework or the home exercise program, I think as a physical therapist, when someone comes in and says that sort of thing to me, like, awesome, we're going to make it work. And sometimes therapists have flexibility too within, I know the clinic that I work in, we have kind of a scholarship fund that employees put money into to help cover a patient's care when there's a situation similar to that. So again, the only way you're going to find out about those things most likely is to speak up and explain your situation, and hopefully the therapist will work with you to optimize your care.
I just would have to just say I completely agree. I think we, as physical therapists, we are definitely interested in just maximizing everyone's time and resources. So super open to working with families to make sure that the goals of care get met, but yet, not putting anyone in time or financial strain.
So we have one more question here, and I think then we'll have to wrap it up for the evening. And so this question is about whether or not either of you have used the ICFCY, the International Classification of Function for Child and Youth, to analyze cases with CMT.
The ICF model?
Yeah.
I
don't know the last piece of it, though. I mean, we definitely utilize ICF model frequently in physical therapy.
I think, as I understand the ICF model, and it's more from an academic perspective, we certainly, it's looking at the patient from all different angles, and we do that with all patients in terms of looking at their environment, their role within society, the cellular impairments from a physiology perspective, as well as the impairments of how it affects the person as a whole. Again, it's kind of a framework that we use as physical therapists to prioritize and figure out how to best identify the optimal plan of care. And so I have not seen like a case study written up regarding the patient with CMT and using that model specifically, but it's certainly kind of a framework that we all have in our brains and work through. I don't know if that answers the person's question.
I think it probably did. With that, I just want to say thank you very much to both Katie and Amy. I thought it was a really interesting set of questions. And to everyone out there who asked all these questions this evening, I mean, that's really terrific. That's what these webinars are supposed to be like. Hopefully you got a lot of good answers. It sure sounded like it. So Katie and Amy, thank you very much. I don't know if you have any closing words for everybody that you'd like to say.
Thanks for listening.
Absolutely, and I think you can reach both Amy and I through the CMTA if there are other questions that we can help with.
Certainly.
Excellent. All right. Well, with that, I'll say good night, and I hope everyone has a safe evening. Thanks very much for listening.
Thank you.